host, Dr. John Bennett, broadcasting from Miami Beach, home of Neurosurgical TV. Today we have the pleasure of having Paulo Pereira, with whom I televised the conference a few years back on World Spine in Porto. He's back today. He's going to explain the topic, and Paulo, welcome, and it's all yours. Take it away. Thank you.
Thank you, John. So let's try to share my PowerPoint presentation.
Okay.
Full screen. Is it working?
Yes, it is.
Great. Okay. So let's start with this. First, I'd like to thank John for making this possible, and to Professor Hypsharian for the initiative. I think it's really great. When I was a resident to listen to presentations, we always have to spend a lot of money and to travel around the world. And well, nowadays technologies put this easier for us, and also it creates new opportunities to learn and to teach. So my name is Paulo Pereira. I'm a neurosurgically trained, but I'm a spine surgeon. I just do spine nowadays in Portugal, and this topic is about, well, minimal invasive OLIF. OLIF stands for oblique lumbar interbody fusion. OLIF is this technique is more known as a OLIF, but as a matter of fact, OLIF is a brand name for Medtronic. So we should call it anterior to psoas lumbar interbody fusion. Probably it's the more correct designation for that. So this is where I come from. I'm from Portugal. So Portugal is in the westmost part of Europe, as you know, and Porto is the second city of Portugal. It's well, it's a nice city with a lot of culture. It's a World Heritage City by UNESCO, and it's if you haven't visited yet, I look forward to seeing you here one day. So, as we know, we have a lot of possibilities for interbody fusion. We can go posterior, anterior, lateral, or wherever, but still, it's like a soup letter. But still, the workhorse of minimal invasive lumbar interbody fusion is still TLIF. So TLIF works very well. This is one of the papers we have published some years ago with an international study with 19 centers around the world, and well, the results are very good. This reproduces what you have, what you see in the literature, also in the short term and in the long term follow-up. So why should we think about other kind of techniques if we have a technique that works very well? Again, when you look at the picture after minimal invasive TLIF like this one, you can what you see depends on what you are looking for. So you can look at this like you see, well, the screws are correctly placed, you have a good interbody fusion, the cage is there, so probably the things should be, it seems good. But again, it always depends on your eyes and what you want, what you are specifically looking for. And you can see like that, but you also can look at this and see that you have no lordosis there. And it's really difficult to get a lordosis after a minimal invasive TLIF. This is also a study that we have published with years ago with looking for our postoperative results, and basically the lordosis that you get after a minimal invasive TLIF is about 2 degrees. So if your aim is to achieve some kind of lordosis, probably TLIF is not the best thing to do. And we know from the literature that having the sagittal balance can be important, particularly for deformity patients. Even in after minimal invasive fusion, you have some data showing that the ODI increases as you get more unbalanced. And so when you look at patients that have bigger ODIs postoperative, they tend to have they tend to be more disbalanced in the sagittal plane. So probably getting a good sagittal alignment is important, even in simple cases like 1 or 2 level minimal invasive interbody fusions. So you still have some tricks that you can play with to restore sagittal alignment when you do a minimal invasive TLIF. This is one option, like you see here is the isthmic spondylo, like a grade 2 isthmic, and playing with your instrument like this, you can push the superior vertebra backwards, and you can pull it backwards, and you can restore the alignment as you can see here. You also can play with the cages, try to put the cages more anteriorly, using lordotic cages, but and the question at the end, you can even correct some deformities just with minimal invasive TLIFs. This is such a case. So we did asymmetrical TLIFs on the sides of the concavity. So we did the TLIFs on the left side on this in the lower part, and the right side in the upper part here. So at the end, you get a much better restoration of the sagittal and coronal alignment. Also with this kind of skin incisions. So let's try to. So basically the question is, are you happy with the lordosis you get or not? So if you think that your patient doesn't need to increase the lordosis, it will work very well. So a TLIF is a great surgery, is the most common, for me, it's the most common minimal invasive fusions that I perform. But again, if you want to increase your lordosis, probably there will be other options, and that's what we are talking about. And other options can be going laterally. So what's the rationale to go lateral? One of the things is that you can put a bigger cage, and you can dock your cage in the ring apophysis of the vertebrae, so you have less chance of sinking in the postoperative. So you put a cage like this, it's typically like 5 centimeters long and like 12 or 14 millimeters height cage. So you have a lot of space to put your graft there. So when you do a lateral approach for a lumbar interbody, you rely on direct decompression. So you distract the disc space, you increase the foraminal height as well. So you increase the disc height and the foraminal height. You use a big cage like this, so you have more space to put your graft. And as I will try to show, you have more possibilities of increasing your lordosis and improve the sagittal and coronal alignment. So lateral interbody fusion, usually you can see that with the DLIF or XLIF. Again, DLIF and XLIF are also brand names for companies. So this should we should talk about this as a trans-psoas approach. Is the standard, is the first developed lateral interbody fusion technique going through the psoas. The drawback of this technique, as you see, is that your lumbar plexus is there. So when you go through the psoas muscles, you have more chance to damage the lumbar plexus, particularly when you go to L4, L5, where the lumbar plexus is more anteriorly. And again, so going through the psoas is not possible in L5S1 because the iliac crest is in front of you, and sometimes if you have a high riding iliac crest, you cannot sometimes you are not available. It's not possible to do it in L4, L5 sometimes. So if you go through the psoas, you should really consider to use neuromonitoring to try to decrease the likelihood of the injury to the plexus. So what are we talking about for OLIF or anterior to psoas or pre-psoas approach? So the rationale is that instead of going through the psoas as a direct lateral approach, you go a little bit more oblique and anterior to the psoas. And what you do is that you have this window to enter the disc between the vessels and the psoas. So if you are more anterior, you will avoid all the lumbar plexus that are projecting here. So there is no risk or much less risk to the psoas, and you'll get, it's still a direct approach, but your entry point in the skin, as I will show after that, will be a little bit more anterior. So this is a picture, intraoperative picture. So this is posterior, this is anterior. So this is the drawing of the posterior and the anterior part of the discs. So if you were doing direct lateral approach for both levels, you will put your incision here. So you go directly to the disc. With the OLIF or anterior to psoas, your incision will get about 5 centimeters more anteriorly. So again, this is the kind of trajectory that you see. So you don't enter directly lateral. So these were the drawings here. So this was the anterior and the posterior part of the disc. So this is anterior, this is posterior. And so your skin incision will be a little bit more anteriorly, and your trajectory will gonna be more oblique. So there are unique features of this approach. One is that, as I said before, you stay away from the plexus. So the plexus is here. So you go a little bit more anteriorly. So you dissect through the three layers of the abdominal wall. Yeah, you see the retroperitoneal fat and the peritoneum. So you do a blunt dissection with your finger to push the peritoneum anteriorly, and then you will touch typically you put your finger, palpate the transverse process. From there, you will see the quadratus lumborum is there. Here is the psoas muscle, and you go anteriorly to the psoas, and then you enter this area, as you can see here with this oblique approach. So doing this, you avoid the plexus, like I said before. Another unique characteristic is that your entry is going to be anterior to the iliac crest, so there is no limitation for high riding iliac crest, as you can see here. So this is a patient that you could not do a direct lateral approach. There is some questions here. Let's try. Okay, about the ureter. I'll talk about this. Thank you for the question. I will talk about ureter now. So the ureter basically comes together with your peritoneum. So when you push the peritoneum anteriorly, the ureter goes together with it. So you never see, or almost never see, the ureter. So let's try. So if you try to do this with a direct lateral approach, people will tell you, so this is not a good case for that because you have the iliac crest projecting over your disc space. With OLIF, since you go more anterior, your incision will gonna be here, so you're gonna be anterior to the iliac crest, and then you will reach this more obliquely. This is another view. This is L5 vertebra. So for L5, L5, you will have the ilium here. So as you go more anteriorly, you would go through here, and then you dissect everything. So the ureter together goes together with the peritoneum, goes anteriorly. So, oops, going next case. So, okay, another one. So another difference from direct lateral approaches is that the positioning is very strict and very direct. So when you do a press-over approach, you just put your patient in a right lateral decubitus, and that's all. So you don't have to tilt the table, you don't have to bend the table to increase the. When you do a direct lateral, you typically tilt the table because you want to increase the size between the ribs and the iliac crest, and then you try to have an orthogonal approach. So you rotate the patient you rotate the table until the disc is perpendicular, direct perpendicular. The other thing that you should do when you do a transpsoas approach is to flex the upper leg to decrease the tightness on the psoas, so the psoas is more relaxed. In a press-psoas approach, you don't have to do nothing of this because you are not. It's even good to have the psoas more tight because you palpate it more easily, and since you are going anterior to it, you will not injure anything. So it's a true direct lateral approach, direct right lateral positioning, and nothing else. And the other thing is also better for ergonomics. So you stand anteriorly to the patient, so you are in front of the patient, and your X-ray can still be there. So you can still be working with your X-ray in place. So opposite to a direct lateral, you don't have to have your all the time your C-arm going in and out. So so you are going more anterior to this, and so you keep, as I said, you can keep the C-arm in place because this is your approach, or you are going more anterior to that. So these are some of the advantages of this technique, and you also have less risk of neurological symptoms because you don't injure it, you don't touch the plexus, you stay anterior to the plexus, and you have less risk or psoas hematoma because you are anterior to the psoas. Still, it's very important to check your anatomy. I will come back to this. So look at you don't need to do a CT angiogram before, but you should look at your CT scan, and for instance, if you have you can have look at your vasculature. Sometimes you have the veins in front of the disc, and you have to decide if you have enough space here to go. For instance, in this patient, you have a long, a lot of veins here and the artery, so it would be difficult to get a good approach on this patient. So I will try to show briefly how it looks like in a surgical video. So let's try, and I will stop and see what we have been saying. So it's the right, so back. So it's the right lateral decubitus, as you can see here. No tilt on the table, so you just tape to secure the patient, and then you drape. And then these are the marks that you typically don't need to do, but that gives you an idea where you are. So this is posteriorly, this is anteriorly. So this is the posterior margins of the discs. So again, your entry point is about 5 centimeters anterior to the anterior border of the discs. So again, you do your skin incisions, The first thing I do is that, oops, sorry. Next thing I do is always, I go to get bone from the iliac crest. So I retract so the iliac crest is gonna be here. So I just retract the skin and the subcutaneous tissue. I open the thoracolumbar fascia in front, the external oblique fascia over the iliac crest and remove bone for grafting. So this is what I'm showing here. So opening, this is the iliac crest, and I'm removing graft there. And then I close the fascia there and go directly where I want to go. So I do a different opening of the fascia if you want to collect bone. If you use an allograft or BMP or whatever, of course, you don't need this step. So now we're gonna open the external oblique fascia here. So this is going to be the external oblique, and then you have to, so you just dissect the fibers, dissect parallel to the fibers, then you'll have the internal oblique here with the fibers running perpendicular, and then you dissect the internal oblique. So external oblique here. Internal oblique there, and then this was the transverse, and this is already the retroperitoneal fascia. So after opening the fascia transversalis, you will see this retroperitoneal fat, and then you'll start dissecting and pushing the peritoneum anteriorly. So this is the genitofemoral nerve. So this is the psoas muscle. So we are going anterior to the psoas. So this is still the same. We use this first. It's a modified like Jamshidi needle because it's blunt. This was designed to use with neuromonitoring. So I don't connect this to neuromonitoring in anterior to psoas approaches, like I said before, but I still use the same introducer because it's blunt and it doesn't damage any vascular structures when I operate. So you put it in the disc. you check in the X-ray, and then you use your dilators. So the peritoneum and all the abdominal content is anteriorly, was displaced anteriorly. So this is the front of the patient again, this is the back of the patient. So after that first introducer, you put the K-wire inside, and then you put all your dilators around the K-wires to reach the disc, as you are going to see here. So these are the dilators. And then you will have this kind of retractor that you fix to the table to keep it in place. You block, so you block it there, and then, oops, back, sorry again. What about here? And also an important step to help to get it more fixed is that you use a screw in the, you use this screw goes in a small orifice that you have in your retractor. So this retractor have a little space to put a screw that helps you to stay much more stable, so it doesn't move a lot at all during your surgery. So this, every time so again, so again here. So you will have your working channel here. So this is your retractors, and this is the screw that docks in the upper or the lower vertebra to help gaining stability. So then you will have a little bit of you just burr small soft tissue that you have in front of your disc. So again, if this is anterior, your psoas will be retracted anteriorly. So you are anterior to the psoas, so the psoas will be here. So this is anterior, this is posterior, so the psoas will be there. So this is the disc space directly. So you do your opening in the disc space, and you prepare, you cut the annulus, and you do your discectomy as if you were doing an ALIF. So you just have a big space to work. So you have the shavers, you have the curettes to remove as much as possible of the disc. And then you check in the X-ray the size of your. It's important that you keep it anteriorly. And another important thing that you are going to see here is that once you go in the disc and you want to, and you start to put your cage and to prepare the contralateral side of the disc, it's very important that you cut the annulus on the contralateral side on the disc, and that you do what's called an orthogonal maneuver, so your approach is oblique from anterior to posteriorly, as you can see here. But if you progress like this, you can enter the canal on the contralateral side. So to avoid this, you will have to push your hands backwards so that you go perpendicular to the disc. I'm gonna show you this here. So this is to cut this will gonna be to cut the annulus on the contralateral side. As you see in AP that your cob goes past the vertebral body so that you cut the contralateral annulus there. Then this is the template. And this is the cage. And as you're gonna see, I will put the cage perpendicular to the patient and perpendicular to the disc space. So you enter like this, a little bit oblique, but then you have to, you have to go backwards so that the cage is inserted there. And so this is final. So I always, so this was a 2 level, so this is the second cage, again perpendicular to the patient, and the 2 cages are there. So when you start removing it, you start removing the retractor, the psoas is there, so you are all the time anterior to the psoas, and all your abdominal content and the retroperitoneal fat will come into place again, and you will see the three layers, and you open. I always back this up with the percutaneous screws posteriorly. So what you gain with this? You gain lordosis, as you can see on this patient. This is a patient that was kyphotic, and you see that the nice restoration of the lordosis here, and you can restore sagittal coronal alignment when you do multi-level. You see this patient with this kind of coronal imbalance that was corrected after a 3-level OLIF, and again, the same regarding the sagittal alignment. All of these discs are collapsed and parallel to each other, and you get a very nice lordosis here. This is another example with the lateral aesthesis that was corrected with the 2-level OLIF or press-psoas approaches. So this is not for major deformities. This is basically what you get. With lateral approaches, you get about 10 degrees of lordosis for each level that you perform. So if you do like a 3-level, you will end up with about 30 degrees. That's very similar to what you get with a pedicle screw, a pedicle subtraction osteotomy, and you will have a more smooth lordosis because you gain some lordosis in each level and not all the lordosis in the same level. You can increase it. You can increase the lordosis using hyperlordotic cages because they are easier to use in the lateral, to position in the lateral approach. Comparing to posterior approaches, you can gain more lordosis if you resect the anterior longitudinal ligament. It's what's called anterior column release. This is typically the maximum correction that you can get. So if you have a patient with a major disbalance, probably you should not use this kind of techniques. So when you compare lateral approaches to posterior approaches, like PLIF or TLIF, there are some advantages. Of course, you don't go inside the canal, so the risk of having a dural tear or nerve root injury or the injury to the dorsal root ganglion is basically avoided. And so you have no epidural fibrosis as well because you don't go inside the canal. When you compare this to typically anterior approach like an ALIF, you have less risk to the anterior vascular structures because you are in between the vessels, and the psoas, you also avoid the sympathetics and decrease the risk of retrograde ejaculation and all these kind of complications. So there is also an alternative to go to L5S1. That is something you cannot do in the direct lateral approaches. So in XLIF or DLIF, you cannot do L5S1. Here you can do it, but basically the approach is like an ALIF. So basically, OLIF between L2 and L5, you go between the psoas and the vessels, and when you do L5S1, you go below the bifurcation of the vessel. So basically, OLIF 5.1 is like doing an ALIF in using the patient in a lateral position. The main advantage for me is that the abdominal contents stay away, so you don't have to, so it's easier to go, and particularly if you have patients that need L5S1 and also L4-5 or 3-4 interbody fusions, you can have all of these with different incisions, but with the patient in the same position. So this is what I was telling about the abdominal contents. So since you are in the lateral position and after you retract the abdominal contents, so you can, they will not be in your in front of you. So the position is still the same, right lateral approach, and the incision is different. So basically what you measure is you measure the projection of the L5S1 disc, and this can be like this or much more oblique depending on the pelvic incidence and the shape of the pelvis of the patient. And so your incision will be about 2 finger breadths anterior and above the iliac crest, and in between the vertical line that comes from the center of the L5S1 disc and the projection of the L5S1 disc. So if you project anteriorly this disc, the orientation of L5S1 disc, and this, if you continue this line anteriorly and you do a second line, a vertical line in the center of L5S1 disc, your incision will be in between these two lines, about 2 finger breadths anterior and superior to the iliac crest. So the other thing is that you still have, your approach will be lateral to the rectus muscle. So this is, so you go lateral to the rectus. So this is your entry point for L5S1, and the rest is the same. So you dissect, you push the abdominal contents and the peritoneum anteriorly. So this is you strip off the peritoneum from the psoas and you go more anteriorly here. So you palpate the common iliac artery on the left side, and then you go anterior to that. And so typically what you're gonna get is a space between the left common iliac vein and the right common iliac artery. That's the most typical, the most common anatomy here. So again, as I was saying before, and regarding the question that I had before, when you sweep the peritoneum, the ureter typically goes together with it, together. So all of this comes together, and you push all of these structures anteriorly. So you're gonna get your space here. So you have, using this, you typically have this kind of retractors, not the tubular retractors. So those retractors were designed for this approach as well. So you have one retractor that is like this. So it's like the retractors that you use for cervical spine. But again, it has a space to put a screw there. So you palpate, you dissect the left iliac vein, you retract a little bit the iliac vein, and you put this retractor and secure it with a screw, and then the other one will go around the disc space, and the vessels will go together with it. So at the end, you'll have this kind of, you can put a third retractor cranially if you need it. It depends. Not all the times you need this third retractor. So this is the left retractor. This is the right retractor, and this is going to be the disc there. So you can have limitations for these approaches, of course. If you have, I will talk about vascular anatomy in a few moments, and it can, of course, if you have patients with thrombus in the arteries, with lower extremity arterial insufficiency, patients that are morbidity obese or have a lot of scar in the abdomen from previous surgery are not the best candidates, of course. And this is what I was talking about regarding vascular anatomy. So in front of L5-S1 nerve root, typically the space that you have in about 2/3 of patients is in between the left iliac vein and the right iliac artery. So this is the most common. So the artery you typically have no problem, because it will stay away when you put your retractor here. It will push the artery laterally, but the iliac vein typically you have to dissect a little bit so that you can have the retractor on your side. You also have variations. Sometimes it's also the veins in both sides, so you have to look at your vessels. The other thing it's important, again, this is a demonstration of what you can see in the CT angiogram, is that typically in front of L5-S1 disc you have the left iliac vein. This is the artery here, so you had already the bifurcation of the internal and external arteries here, and on the right side you typically have the artery more medial than the vein, so it's easier to put your dissector here and your retractor there. So again, it's important to look at the size that you have for your approach. If you have a small percentage of patients can have a very narrow window here, so probably if you have a patient like this is not the best approach for this patient. And of course you can have different kind of variations, like internal iliac vein coming not from the bifurcation but from the left iliac vein, so you have to look at those possibilities. Another thing I like to do to see in my patients is that if I have some space here in between the left iliac vein and the disc or the periosteum. So when you have this, you don't see this space. It doesn't tell you that you cannot. Sorry, it doesn't tell you that you cannot do your surgery, but it's much more easy to dissect here than to dissect here, because this will be more packed together and more stick, and it's going to be more difficult to dissect. Again, typically what you have, left iliac vein here, right iliac artery there. Of course, you can have complications like infection, you can have a retroperitoneal hematoma. So when you remove your screw and the screw that is holding the retractor, you have to look at that and see if everything if nothing is bleeding, and of course you can have abdominal injury to the abdominal contents, and you can have a transient postoperative ileus as well. So so when you do when you can do this, you can combine patients that need multi-level fusions. You can use a press-over approach on the upper levels, and the ALIF, let's say ALIF done in the lateral position for L5S1. And again, this is the position of the retractors that I showed you. Typically, you have this is the first retractor that you put, trying to hold after dissecting the left iliac vein and keeping it in place, and then the other dissector goes to the contralateral side, and you can put a third retractor if needed cranially. So, and this is what you can do. As you can see, you can combine. This patient has 3 lateral interbody fusions, L2, 3, 4, and 4, 5, like in a press-over approach, and with the patient in the same position, we did L5S1 OLIF. So it's an ALIF done in the same lateral decubitus position, and then the percutaneous screws posteriorly. So shortly, I will end up with 3 cases just to explain what we are doing and why in cases in which cases we are doing that. So this is a 51-year-old lady with mainly low back pain, but also pain radiating to the left side, to the knee. It's been progressive, worse on loading, with standing, walking, and improves with when she's resting. No neurology, failed conservative treatment for more than 1 year. And this is the MRI, the sagittal MRI. So you basically see a grade 1 degenerative spondylo with some disc bulging as well, creating stenosis in the canal, and you have this kind of the tortuosities of the nerve roots. That is a major sign of lumbar stenosis, as you know. And you also have on the left side foraminal stenosis. That's what is causing the left side pain. This is the compression of the L3 nerve root in this foramen. So this patient has a central and the left foraminal stenosis. So this is the right, so on the right side is okay. This is the X-rays, so a grade 1 degenerative spondylo, and minor asymmetrical collapse of the disc, and nothing very different on flexion extension. So this is extension, this is flexion. So this is the lysis is about the same. The coronal and sagittal balances are not so bad as well, as you can see from here. And this is what we did. We did a lateral approach, and we could restore this height. We lost some of it because, as you can see here, this is also to show one of the possible complications is that you have some sinking of the cage in the lower vertebra. So this can happen particularly when you are too aggressive on removing the disc and on using the shaver. So if you use the shavers too aggressive, you can injure the end plates, and you can with that you lose the part of the possibilities to restore your lordosis. So this is pre-op and post-operative. Second case is another lady, 56-year-old, no major comorbidities, low back pain for more than 10 years that has been progressive. This is her main complaint, and also neurogenic claudication during the last 2 years. Also progressive. Now she has a walking distance of less than 500 meters, and she tried a lot of different things, medications, rehabilitations, epidural steroid injections, some improvement, but not enough, and the walking distance is worsening. So this is the sagittal MRI. Again, you see this kind of spinal stenosis. Again, the tortuosities of the nerve roots, the serpiginous shape of the nerve roots here, and you have a central stenosis in L2-3, 3-4, and 4-5. In L4-L5, you also have a disc herniation here, an extrusion going caudally. And in L4-5 and 3-4, you have a degenerative spondylo grade 1, as you can see here. L5-S1, no stenosis, and the disc is not that bad as the other levels. So this is the X-rays. So again, the degenerative spondylo in L3-4. That's worsening on flexion comparing to extension. When you compare the slip is bigger on flexion than extension, and the other levels are okay. So putting all of this together, of course, doing the decompression alone probably is not a good thing, particularly for L3-4. So in L3-4, this patient has a spondylo that possibly would progress if you did just the decompression. And also you could do a decompression on the upper and lower levels, but also there is a lot of back pain. And there was a disc here, disc herniation, as you remember, in L4-L5. So we decided that doing a 3-level fusion could be a reasonable option, trying to deal with all of the problems together. So this is, again, the sagittal and the coronal profile were okay. And so we did the 3-level lateral approaches. So we gained some lordosis here. With a press-over approaches. Also, you can see here that the more anteriorly you put your cage, the more lordosis you get. So this is a little bit more posterior, and lordosis is not that good. And the other thing still is quite better than before surgery. And the other thing I'd like to show you is this postoperative image. So even the disc protrusions that you have before the surgery. So this is the preoperative. So we didn't do any posterior approach. We just did the percutaneous stabilization, pedicle screws percutaneously. So we didn't go inside the canal, and we didn't go posterior to do any kind of decompression. And as you can see here, since you distract the disc space, the infolding of the yellow ligaments disappear, and you gain, this is what's called really an indirect decompression. Even the discs, even the protrusion, the small disc herniation that we didn't address directly. So you gain, you don't have these tortuosities of the nerve roots, you have much more space just doing anterior approaches and just doing distraction of the disc space. So this is what I would like to show you in a postoperative comparing to preoperative MRIs. And last case is a 45-year-old lady with radicular pain in the left leg down to the tibial crest for 2.5 months, multimodality conservative treatment, also some decreased sensation, so some sensitive neuropathy, and some moderate low back pain, which was not the main complaint. So the main complaint was left leg pain, and this is the MRI again. So this, you have this disc herniation and degenerative spondylo, again grade 1, as you can see here. And we also did a lateral approach to address all of this, to increase the foraminal height as well, to increase the size of the disc space, as you can see here. And again, this is pre-op and post-operative. Here on a CT scan, the cage is there, and this is the spine, the case you can gain. Lastly, this is a lady with neurogenic claudication of over 18 months, and this is here because this is to show you that this is the cases where I don't consider going laterally, because you have a lot of bony stenosis, so you have calcification of the yellow ligaments, you have a very tiny canal, very severe stenosis, and on cases like this, I still like to decompress directly the canal. On this case, we did a mid-LIF that is basically a posterior approach, a posterior decompression, just decompressing all the thecal sac. And the only difference to a conventional approach from the midline is that you have a much smaller incision here because you have this different trajectory of the screws, that you put. It's what's called cortical screws, because you enter from caudal to cranial and from medial to lateral, so you don't have to expose as much. But this is the kind of patients I don't like to do on indirect decompression, and try to rely on direct decompression and seeing the dura and the nerve roots. And again, it's always a question of the hammer and the nails, and if you have different options in your armamentarium, possibly you can better tailor what you want to achieve to the patient that is in front of you. So I'm not saying that, like I said in the beginning, considering minimal invasive lumbar fusion, the TLIF, minimal invasive TLIF, is still my standard technique, but I try to show you that the going lateral, and particularly going anterior to the psoas, can have advantages in a set of patients, in some of our patients, and is an option to consider. So I'll be happy to answer questions in case you have some.
Okay, Paulo, thank you very much. Okay, this is a very interactive. Paulo was experienced at giving these presentations, so he knows how interactive it can be, and we encourage people in the pay. You want me to get you off that, Paulo? I can
Okay.
just, yeah, I can get you. I basically.
I just can share the screen, right?
There you go. You're off the screen now.
Okay. So
okay.
Just go to the, okay.
Did you want to get back on the PowerPoint, or?
No, that's good. So
okay, let's see
Ureter, I have replied to this. Which type of anesthesia I do the procedure? I do these procedures with standard general anesthesia. So all of these patients are done in a general anesthesia, and I have the patient in lateral positioning, and then I tilt the patient to do percutaneous screws. On some patients, so I typically do the second phase. So the percutaneous screws I typically do immediately after the lateral approaches. The exceptions are some patients that I might be concerned with the indirect decompression, and I want to be sure that after indirect decompression they don't have radicular symptoms. And on these cases, on cases like this, sometimes I stage the procedure. So I do the lateral approaches, and then I have the patient walking in the ward for the next days. And if the patient still have radicular pain, when I do the posterior approach, I decompress that nerve root. But typically it's done in the same procedure. So another question from Genial: any experience of using Pivox plate, or you use percutaneous pedicle screws? This is also another a very good question. That are some cages that including have embedded some fixation device, either a hole for screws that you can put something similar that you can use for some cervical or ALIF cages. So you have like a through where you can put a screw, or you can or some cages have some kind of blades that you hammer, and they go in the upper and lower vertebra. And also the third possibility is doing a lateral plate, as you say. I prefer using percutaneous screws because I feel that they are more stable, particularly in flexion. When the majority of cases that I do, I have deformities like I showed you, or have degenerative spondylo, so I feel more comfortable to have percutaneous screws that restrict flexion better than lateral plate. But still possible, particularly for patients that don't have a major instability. I think that using just lateral fixation can be a good option. I know that some surgeons are also using these cages as standalone, so nothing posteriorly. Well, I'm a little bit reluctant to do this. As you know, the literature showed us that standalone cages are not good for ALIF. So why should they be good for a lateral approach? But again, if you have no major instability, or if you have only degenerative disease, eventually putting just a cage can be okay. The other thing is that a few patients that I have staged, for the reasons that I said before, that I do the posterior, the lateral approaches on one day, and having the patient walking on the ward to see if they have radicular symptoms after that. Typically, those patients have significant back pain in the last few days that disappear once you put the percutaneous screws. So that's the reason why I keep doing percutaneous screws. Also, it's a fast thing to do, and we are very used to do that. So next question from Ahmad Abdullah is, where is the patient stay in the hospital? It's about 2 days. It's about 2 or 3 days maximum. Usually the standard is the patient stands up the next day, walks around, and if everything okay, the second day he is discharged. So there's also a question from Gonzalo Gomez. How does the fat influence the surgery? Are there papers about this topic? The difficulty of the fat patients tend to have thin peritoneums that are more difficult to dissect, and the bigger the patient is not just the fat, but the bigger the patient, the most difficult it is to reach the lateral side of the spine, and you have to use a longer tube, a longer retractor. So when you use a longer retractor, it's more difficult to work because you have to put all your instruments through that tube, and the longer you have, the less possibilities of angulations. But we have done it on fat patients. The patient I showed you the video, as you could see from the first image of the positioning, it was a fat patient and we had no problem at all. So directly answering, I think there is no contraindication, but it can increase the difficulty of the surgery.
Okay, do you see any more questions, Dr. Pradella?
Okay.
Okay.
We're done.
Yeah, let me just see if the panelists, does anybody have any questions they want to ask directly to Dr. Pradella? Hello, Abhilash. Good day. I want to introduce you to Dr. Pereira.
Yes.
Hi, Abhilash.
Yes, good morning.
Good morning. I'd like you to meet Dr. Pereira. Dr. Pereira.
How are you?
Yeah.
How are you? Where are you from?
Tampa, Florida.
Ah.
Yes.
Yeah,
Good weather there, right?
Yes, big Ronaldo fan, so.
Okay.
Yeah.
I'm not a soccer fan, let me tell you.
I didn't hear that, so.
Okay.
Yeah, you got Brady now, right?
Yeah, we have Brady, that's great.
Well, things are going to change, I think, in Tampa.
Yeah.
But yeah, Dr. Pereira is a very prominent spinal surgeon from Portugal. And he gives conferences. So part of the value of this is networking, meeting who's out there, and matter of fact, Dr. Goel, how you doing? Are you here already?